Hi fellows, it's Jenny here. I'm going to be recording some of my talks and this is the first one. This is a talk entitled What Should Be the Initial Imaging Modality for the Workup of Primary Hyperparathyroidism? And as you know from working with me, the answer is 4D-CT. In the next couple of minutes, I will be presenting an argument that 4D-CT should replace scintigraphy as the primary imaging modality for this problem. And this is from three perspectives: the data, what the studies tell us, the patient's perspective, and then the surgeon's perspective. But before we look into these arguments, let's have a look at a couple of cases. In this case, the parathyroid adenoma is actually at the level of this SPECT CT image, but you can't see it. It's seen on the arterial phase 4D CT. It's the right lower location, less conspicuous on the two other phases, but really well seen on this sagittal image showing a fat plane between the adenoma and the thyroid. This next case is a parathyroid adenoma in the right paraesophageal location, which is now seen in retrospect on the scintigraphy study, although it was called negative initially and possibly confused with uptake in the esophagus. And this final case is a tricky one. This is a cystic solid lesion that was seen on ultrasound in the left upper location, but on 4D CT, there were additional lesions that were hyperenhancing. This one in the right lower location that's also seen on the axial images. There was an additional lesion posterior to that at the same plane, and then in the left lower location, another hyperenhancing candidate lesion. All of these were parathyroid hyperplasia at pathology. So now let's turn to the data. Since 4D-CT was first described in 2006, there have been multiple studies that compare this relatively new imaging modality to traditional imaging modalities, and I have summarized them for you here. This table shows the study sizes in the last column, and then the other numbers are the sensitivity of the different imaging modalities. In all of these studies, with exception to the last one, 4D-CT had a higher sensitivity than scintigraphy by various margins, but these are clinically significant margins. And why is that? Well, we tried to answer that question in this study where we looked at factors leading to missed lesions on 4D-CT and scintigraphy. And if we looked at the factors that were leading to missed lesions that on scintigraphy that were detected on 4D-CT, here's a list. The most common reason was retained radiopharmaceutical activity in the thyroid. That is, residual uptake on the delayed images obscured the parathyroid adenoma. Then the other reason that was apparent was lesion size. For scintigraphy, the missed lesions had a lower mean size that was statistically significant compared to detected lesions, but this wasn't a factor for 4D-CT, and it speaks to the fact that 4D-CT has better spatial resolution. It's able to detect smaller lesions. In this study, the smallest lesion that was detected on 4D-CT was 4 millimeters, and it was missed on scintigraphy, whereas the smallest lesion detected on scintigraphy was 1 centimeter, and it was also detected on 4D-CT. But that's not all. It's not just about sensitivity. The patient, who is the center of care. What matters? Time. It takes less than 5 minutes to do a 4D-CT study, but 2 to 3 hours to complete a sesame scintigraphy study because of the delayed imaging. Then there's the costs, important to both patients and payers, as well as the radiation exposure. For costs, there are 2 studies that look into the cost effectiveness of the strategies for imaging for this problem. These studies draw on Medicare reimbursement data and we see that ultrasound is the least expensive study. It's less than $100, but 4D-CT is actually less expensive than the sesame study. This study showed this graph, which I think is very valuable, although it can look a bit confusing, so I'm showing you it bit by bit. Here we have a graph with the costs on the y-axis and then the prevalence of single-gland disease on the x-axis, with single-gland disease being on the right side and multi-gland disease being on the left side. The study isolated sesame and 4D-CT as the only imaging modalities, and then concluded that strategies using sesame, whether sesame was on its own with other modalities, were more expensive. And here are the lines on the graph. Scintigraphy is in green here, and it's more expensive than 4D-CT. The costs go up with multi-gland disease compared to single-gland disease. The least expensive strategy was actually to do an ultrasound first and then proceed to 4D-CT if the ultrasound was negative. Radiation exposure. Although there are a couple of studies saying that the radiation exposure is comparable for 4D-CT and scintigraphy, the only study that actually measured the radiation dose by scanning a phantom with dosimeters was a study that we did, and we found that 4D-CT has more than double the effective dose of scintigraphy. However, the mean age of patients with primary hyperparathyroidism is 60 years of age, and these patients are less likely to have the stochastic effects from radiation. And that's shown here on this table, which looks at the increase in lifetime risk of cancer from imaging on the y-axis and the age of the patient on the x-axis. So although 4D-CT may not be the best option for the 25-year-old female patient, when the patient is 60 years of age, 4D-CT does have higher risk of stochastic effects than scintigraphy, but the risk is less than 0.5%. So from this study, we concluded that in the typical patient, we really shouldn't let the risk of radiation be a concern because the risks are really negligible for both imaging studies. Then there's the surgeon perspective. This is what one of my surgeons says. I have virtually eliminated scintigraphy from my practice, and I go with 4D-CT and ultrasound for primary exploration. And this is because of what the data shows, what is important for the patient, and also two other factors. Anatomy. 4D-CT provides exquisite anatomy to help plan surgery to make it safer and less time consuming. These are bilateral retropharyngeal parathyroid adenomas. You can even see a large feeding artery going to one of the adenomas. And then the second factor is confidence. For the parathyroid candidates, we grade them as consistent with, highly suspicious, and possible, representing different levels of confidence. For scintigraphy, it's either a positive or a negative study. And when we looked at our cases of 197 lesions, the consistent with category was actually the most prevalent. And this category had a false positive rate of less than 2%. So if a lesion is determined as consistent with, the surgeon knows that they could safely proceed to surgery, and imaging further with scintigraphy may not actually be necessary. Finally, what do the masses say? What do other people do? We surveyed more than 360 institutions worldwide, and the results are interesting. More than half of the radiologists performed 4D-CT, but only 10% used it as a first-line study in their practice. However, only 28% of the practices have been doing 4D-CT for more than 3 years. So this is a relatively new imaging modality, and there's a lot of experience to be gained from both the patient, surgeon, and a radiologist perspective. And early adopters, those that have been performing it for more than 3 years, were 3 times more likely to use it as an imaging study, first line. So I think this speaks to future trends in the use of 4D-CT compared to scintigraphy. As surgeons gain more experience in seeing this modality, they are probably more likely to order it as a first-line study. I'm going to conclude now, and I'm going to say the first thing is that the choice of modality is really institution dependent, and there may be an institution that is a lot stronger with scintigraphy, and in that institution, that should be the imaging study for choice. But if we're looking at all of the data and other factors, 4D-CT has high sensitivity for sure, especially for small lesions and multi-gland disease. From the patient's perspective, it is more cost-effective to do 4D-CT rather than scintigraphy, and it's also more convenient. And then from the surgeon's perspective, it provides exquisite anatomy and helps grade confidence, allowing clinical decisions to be made. Thank you for listening. I hope you liked it. Let me know what you think. Bye.